Thank you, Gunjan. Thanks, AIOs, for organizing this very important symposium. Can you see my screen?
Yes, sir, it is visible.
All right.
Yes.
So I'll be talking about stage-based management approach, which we are proposing. This was not very long ago. In February, we were able to collect only 6 cases of mucormycosis between Hyderabad and Mumbai and publish. Possibly these were at the end of tapering of the first wave. Second wave had not even begun at that time. Probably it was just the kind of fire that was just lighting up at that time, and we are now seeing a raging fire of mucormycosis. Why does it happen along with COVID-19 has already been explained by the previous speakers. Secondary infection is known in COVID-19, and early secondary infection is bacterial. That is why possibly some of these patients are covered with systemic antibiotics. Secondary fungal infection is known in the second, third week concurrently with COVID infection or following recovery. Now, why does Mucour infect these patients? Mucorales are already present in the nasopharynx and paranasal sinuses. In COVID, what happens is there is a breach in the mucosal barrier which goes on for a very prolonged time. It's not a breach that is going to heal up soon. It continues even for 6 to 8 weeks following resolution of COVID infection. And Mucour simply piggybacks on this COVID infection because the mucosal barrier is already broken. Second theory is that because of the necrosis of tissues that COVID manifests with, angioinvasion and necrosis, Mucour, which is already there as a commensal in that area, infects the necrotic tissue, and then from there on, it carries on. So that's an endogenous source. But of course, Mucour is in every breath you take. As I speak, there is Mucour everywhere around us. So it's an exogenous source which can infect these patients who are predisposed because of the immunity, loss of immunity, and overuse of steroids, etc. That's an exogenous source. So there are both the sources that can affect these patients. Loss of mucosal immunity at the point of entry and point of proliferation is well documented. There is no doubt about that. That is out there in the literature. And also fact that the mucosal immunity continues to remain impaired for a very prolonged time. When we looked at the series of mucormycosis associated with COVID that have been published from various countries, there is a bunch of cases out there. What we find is that steroid use of tocilizumab, patients who are elderly, severe COVID-19, patients who have been on mechanical ventilation and supplemental prolonged oxygen therapy, high pressure or standard oxygen therapy can manifest with mucormycosis. This could happen concurrently during COVID infection or following recovery. Following recovery, even up to 3 months. The latest we have seen is at 3 months following, patient became RT-PCR. Patient did not have a second infection. Patient was on steroids for 6 weeks. That was an indiscriminate use. But what we are seeing currently is this profile as well. Young, immunocompetent, non-diabetic individuals who may have had slight amount of impairment in their glucose control because of steroids, some of them even with no steroids. So this profile of patients is worrisome because it is going beyond what we earlier believed that it affects only a certain category of patients. So why do we need staging? We need to triage. This is like a fire. Mucormycosis has to be dealt with very expeditiously, otherwise it's going to spread. It is actually, the evolution is more rapid than the conventional mucormycosis we used to earlier see with patients with diabetic ketoacidosis. So we have to triage these patients. Who will lead the team? Would it be an ophthalmologist, oculoplastic surgeon? Would it be an ENT surgeon or a critical care specialist, or all of them equally? Risk stratification is important so that we expedite care. Standardization of care is again important because we need to have good results for these patients. So we need to build protocol and build science into what we do. So we have to have staging system which follows an anatomical progression, severity in each anatomical location. So you go to the site first and then the severity, and then based on these two factors, what change we could propose in the management approach. So this possibly will affect the prognosis. Now, anatomical progression follows this pattern conventionally, but there are unconventional patterns that are being followed in this pandemic. First is the point of entry and point of proliferation, which happens to be nasal mucosa, middle turbinate, and inferior turbinate. Then it gets into the paranasal sinus, ethmoid, maxillary, and sphenoid in that order. Ethmoid is the most commonly involved sinus. 70% of the paranasal sinus involvement, predominantly initially, is in the ethmoid. Then the orbit gets involved either through the nasolacrimal duct retrograde through the inferior meatus, lamina papricia to the medial orbit, transsphenoidal to the orbital apex, or as a non-contiguous means through a vascular embolus, venous embolus. Now, brain can get involved through the superior orbital fissure and inferior orbital fissure and optic canal through the orbit and directly from the nose through the cribriform plate. It can also go transsphenoidal, and it also takes one more interesting approach, that is through the pterygopalatine fossa, through the foramen retinum directly to the midbrain, and this can manifest with bilateral third nerve palsy. We have patients who have bilateral third nerve palsy with this particular approach. Then a vascular embolus, which is non-contiguous, and then finally an unconventional way of bypassing all the vascular channels. In the stage that we have proposed, stage 1 is limited to the nasal mucosa, which could be in the middle turbinate, inferior and middle turbinate, and the ostium of the NLD, involvement of the nasal septum, and bilateral nasal mucosal involvement. Obviously, this would need a diagnostic nasal endoscopy. These are the symptoms that are associated at this stage: nasal stuffiness, discharge, foul smell, and epistaxis. And on signs, nasal endoscopy is mandatory to diagnose at this stage. These are the signs that you would find, and contrast enhanced MRI, which is preferred. Diagnostic modalities, I'll talk a little later at each stage, but basically this is what you find. And in on MRI, the first sign on MRI is supposed to be a black turbinate sign. Because of ischemia of the middle turbinate, the mucosa does not enhance. As you see here on the right side, it is enhancing, and if in the left side, it is gray-black, and that is the first sign. Second sign is mucosal hypoperfusion. See, ipsilateral side, there is hypoperfusion of the mucosa, whereas contralateral side, the mucosa is normally perfusing. So MRI is important to contrast enhanced. In the paranasal sinus stage, we have either one sinus, two ipsilateral sinuses, more than two ipsilateral sinuses, or involvement of the palate or oral cavity, and bilateral paranasal sinus involvement. In this stage, patients present with facial pain, facial edema, dental pain, or a sudden tooth falling off, which was otherwise healthy. Systemic symptoms can also start at this stage. In this stage, every sign that was seen in stage 1 can be seen. Apart from that, there is unilateral or bilateral localized or diffuse facial edema, edema localized to the sinuses, and localized sinus tenderness. Again, diagnostic nasal endoscopy and MRI are important at this stage. This is what you see initially in stage 2A. You find an ethmoidal sinus involvement, as you see here. And when it progresses to a maxillary sinus, which is contiguous, then you can also see black turbinate sign here. That is stage 2. Here, what is seen in here is the infraorbital nerve is getting involved. On MRI, this can be very well delineated. At this stage, patients present with infraorbital nerve hyposthesia or anesthesia, or perialar anesthesia is also known. That's involvement of the palate, and bilateral paranasal sinus involvement goes to stage 2D. Then in the orbit that we are very concerned with as ophthalmologists, initially it can go through the nasolacrimal duct to the medial orbit. At this stage, vision is unaffected. Then diffuse orbital involvement, which is defined as more than one quadrant or more than two structures, still the vision may be unaffected. When there is central retinal artery or ophthalmic artery occlusion, or superior ophthalmic vein thrombosis, or involvement of the fissures, superior or inferior orbital fissures, orbital apex, and loss of vision, which is the most severe form, this goes to stage 3C, and unfortunate bilateral orbital involvement goes to stage 3D. Here, the patient presents with proptosis, which could be mild, pain in the eye, ptosis, diplopia, loss of vision, which could be sudden or gradual, infraorbital and facial or V1, V2 nerve anesthesia. Now, signs are conjunctival chemosis, isolated ocular motility restriction. For example, if the medial rectus is involved, abduction will be limited because it's an inflamed medial rectus. It doesn't mean that the patient has lateral rectus involvement or lateral rectus palsy. Ptosis, which could be sudden onset or gradual, proptosis, infraorbital nerve anesthesia, central retinal artery occlusion, features of ophthalmic artery occlusion, and superior ophthalmic vein thrombosis. Then all these that can happen because of involvement of the superior orbital fissure, inferior orbital fissure, and the orbital apex itself. So patients will come present with whole lot of ophthalmic manifestations, of which sudden loss of vision and sudden loss of ocular motility disturbance and diplopia and ptosis are very important to pick up. Here, contrast enhanced MRI takes the lead role in diagnosing the extent of orbital involvement. This is a patient who has early orbital involvement presenting with obviously she has a periocular edema. This is periocular discoloration, which has a progressive change in color. Initially, it could be erythema. Then there is a temporary phase of pallor, that is the onset of ischemia. Then there is bluish violaceous discoloration. Finally, it settles down to a blackish discoloration. This is a patient where there is isolated thickening of the, sorry, the arrow is pointing around. This is the isolated thickening of the medial rectus muscle in this patient with localized orbital involvement. This is a patient where there is restricted ocular motility of the eye in abduction because of the medial rectus being involved here. You can see gross thickening of the medial rectus muscle itself, but the patient has multifocal disease, so it goes to 3B. This is an isolated involvement of the superior rectus because the lesion is superior, and also the patient has a medial orbital component that also goes to stage 3B. You can see rapid progression in this stage, much more rapid than what we used to see earlier. This patient came with ptosis. We took a nasal swab, and by the time the patient came back with a scan, there was chemosis. So it can evolve very rapidly. Patients also present with sudden onset ptosis, and when you look at this patient in 9 days, you find that there is complete ophthalmoplegia, but she has hardly any proptosis and hardly any conjunctival chemosis or even redness. It's a white eye. So this patient definitely has an orbital apical involvement that bypass the rest of the orbit. This is an example of central retinal artery occlusion. Patients present with sudden loss of vision, but patient can also have compressive optic neuropathy, which manifests with gradual loss of vision. This patient only has mucosal enhancement of the paranasal sinus as the sign. So this patient does not have a full-blown mucormycosis picture, but yet has central retinal artery occlusion. This is not a embolic occlusion. This is the typical one, like a cholesterol plaque, etc. But this is the fungus embolizing into the central retinal artery, or central retinal artery arteritis that can cause central retinal artery occlusion. So it cannot be managed with anterior chamber paracentesis and such. And we understand why all this happens, because the orbital apex is a very crowded space, and everything is in close quarters. So it can start in the superior orbital fissure, very quickly involve the inferior orbital fissure and the optic nerve. This is an example of a diffuse orbital involvement. Now, this is unfortunate that this patient has developed bilateral orbital involvement, yet the proptosis is not yet severe. Patient has progressed from the posterior orbital aspect. Involvement of the central nervous system. Initially, there is focal or partial cavernous sinus involvement, and then it becomes diffuse. And beyond the cavernous sinus, involvement of the skull base, internal carotid artery occlusion, resulting in brain infarction and multifocal or diffuse CNS disease. Patients with cavernous sinus involvement also present similarly as orbital apex involvement, but on radiology, you may find there is partial or complete cavernous sinus involvement. In patients who do not have cavernous sinus involvement still can present with ptosis. That is because of the alternative approach that I mentioned, through the pterygopalatine fossa, through the foramen rotundum. Disease going into the midbrain can cause bilateral third nerve palsy or paresis. That is the approach that it takes. Now, this is an example of brain infarction because of angioinvasion of COVID, and that is a diffuse CNS disease. Now, how do we diagnose? We simply do initially, as soon as the patient comes, well, of course, ideally you should take a swab under endoscopy guidance. But if you don't have that, if you're not well versed with it, then a deep nasal swab can be done, but that has only about 25 to 30% diagnostic accuracy. If you do an endoscopy guided swab and take a swab right from the area of pale ulcer or eschar, not the base of it, but the edge, then the diagnostic accuracy rises to about 75%. We can also do what is called a microbiopsy. This doesn't need that the patient to be taken into the OT. This can be done in the OPD room. As you see on endoscopy, if you find the middle turbinate or inferior turbinate inflamed, or the nasal mucosa inflamed and discolored, just take a small bit of it. The patient does not need anesthesia, maybe topical anesthesia, all that is required, and send it for a rapid histopathology. Microbiopsy is sent for rapid histopathology by squash and imprint and frozen section. And this will give you diagnosis in 15 minutes flat. And this has the very high sensitivity of about 75%. So histopathology with a microbiopsy is what I would advocate in the absence of microbiology being negative with KOH and calcofluor white. Culture, of course, will take time. Fixed sections will, of course, take time. So what is important is microbiology with KOH and calcofluor white and a microbiopsy for squash and imprint and frozen section. Serology and PCR are still not prevalent. Now, about imaging, Milind has very eloquently stated that, well, CT is helpful in diagnosing, but it cannot help in staging the disease. And as Alok was pointing out earlier, CT scan lags behind clinical findings even. But MRI actually is now known that it precedes CT signs, and it can also give you the extent of the disease. It can show the perfusion status in the orbit and beyond. So it is the most important radiological diagnostic tool. Now going on to management triad, if you don't treat, these patients have a very poor prognosis. If a patient is treated with amphotericin B, the medical control alone, 60% may survive. Surgery alone, 60% may survive. But when you combine this, you can actually increase the prognosis by, okay, 10%, but then that is very important. You are breaking the 70% threshold by combining medical management with appropriate surgery. This is how patients are triaged. If a patient comes with probable mucormycosis, then you do an RT-PCR, even if the patient has been tested negative earlier. Then if it is positive, the patient has to be admitted with all COVID-19 precautions. If it turns negative, then you can admit in critical care or ENT department or ophthalmology. So timing is the key in the management. Mortality is 30 to 50% even with treatment. Any delay, earlier it used to be said 6 days delay in starting treatment can double mortality. Now with this situation, it is even 1 day delay can double mortality. It is very rapidly evolving when it piggybacks on COVID. This is what we have proposed. If a patient has symptoms, then that is only possible mucormycosis symptoms in the appropriate setting of having been COVID positive earlier and having received steroids. So setting has to be correct. The patient has the symptoms, it is possible mucormycosis. But you don't have any clinical or endoscopic or MRI or CT scan diagnostic evidence, then you don't treat them as mucormycosis. You closely observe them with supportive treatment every 24 hours, and if the patient improves, then mucormycosis unlikely, but still you observe them for 3 weeks. If a patient has possible rhino-cerebral mucormycosis, and on observation the patient clinically worsens with new onset supportive evidence, then you start on amphotericin. If a patient has clinical symptoms and has also supportive signs, clinical signs, you may not have done radiology yet, but if you find an eschar on endoscopy, that is good enough. You might not have done microbiology yet, but you have sent the swab. While waiting for it, it is important that you should start them on amphotericin B. In proven cases where there is supportive evidence clinically and on imaging and on confirmation on microbiology and on histopathology, then there are of course proven cases, it is mandatory that they are started on amphotericin. Conventionally, liposomal amphotericin in full doses used. There is no role for escalating dose. You can't start at 3 and increase them to 5. It is supposed to be started at 5 milligram per kg body weight for Rhino orbital, and 10 milligram is proposed for CNS involvement with strict metabolic control. Where this is not available, then it is okay to start on deoxycholate and lipid complex, which are less expensive but have a more toxic effect on the kidney. And if the patient has a very short kidney where you cannot give amphotericin at all, then isavuconazole or posaconazole are advocated. Now, after having started the patient on medical treatment, you have to prepare the patient and prioritize surgery. While you wait for surgery, patient to become fit for surgery, it is mandatory that you continue to monitor the progress of the patient or the deterioration of the patient. If the patient is in stages 1, 2, or 3A and B, where there is predominant sinonasal manifestation with limited involvement of the orbit and the vision is preserved, the first surgery that you do is an aggressive debridement or aggressive FES. Then for the orbital component, you can give retrobulbar amphotericin B as Milind described, and sinus irrigation with amphotericin B 1 milligram per ml, and continued debridement with Continued debridement under endoscopic guidance. When the patient improves, you put them on a step-down therapy with isoconazole or posaconazole. If the patient after ENT surgery continues to progress to a stage 3B or C disease progression, worsening of the orbital component within 72 hours, then you have to jump into do orbital exentration. Rest of the management is the same. But if the patient at primary presentation already has extensive orbital involvement and has limited CNS involvement, then you do a primary orbital exentration along with ENT surgery. If a patient has extensive CNS involvement, you can still do surgery if the systemic condition permits, but rest of the management will continue as before, medical management. So indications for orbital exentration, I think Kasturi will deal with it, but typically diffuse orbital involvement, unilateral, no useful vision, no or minimum extension to cavernous sinus, and worsening after FES. We do a lid sparing exentration where possible. If not possible, you can do an open exentration. Lid sparing exentration would help us cosmetically rehabilitate the patient with a custom orbital prosthesis. Some patients may not need exentration at all. This is a patient with anterior cavernous sinus involvement, completely settled down with ENT surgery and also systemic amphotericin B. Now, can we prevent it at all? There are several measures that have been advocated to prevent, but most important is judicious use of corticosteroids only when indicated. I believe that Indian guidelines for corticosteroid use are slightly lax, but if you look at the Western guidelines, they're very, very critical. This discussion has already happened earlier, but dose is important. Dose cannot extend for a prolonged duration. Dose is very clear, and the duration that it is advocated is also very clear. There are red flag signs. Patients who have been discharged after COVID management or still admitted in the COVID ward, you have to look for symptoms such as nasal stuffiness, bad odor, nasal discharge, white ulcer, palatal ulcer, eschar, etc. Some of which can overlap with the COVID itself because of the ICU, use of oxygen, prongs, etc. Patient can have nasal stuffiness. All this can be part of COVID itself. So you have to differentiate the wrong red flags from the right red flags. Progressive eye, facial pain and headache, eyelid and periocular edema, facial edema, discoloration, proptosis, sudden loss of vision, sudden ptosis, and diplopia. Patients should be forewarned that if they manifest with any of the symptoms, they should seek medical consultation immediately. So this is very important to understand the disease in its entire perspective. Incidence is just 1 in 10, 1,000 in admitted patients so far. 8,000 plus cases have been reported. Based on that, this calculation can be made. And 2 in 10,000 patients in all PCR positive COVID-19 patients. So it is not that the incidence is very high at this point in time, but yet it is alarming because this is a very ferocious disease. And everybody can obviously duly get alarmed because of the nature in which it manifests and progresses and takes away life. But because of the rarity, general screening would be a burden on the already burdened medical system and would be very ineffective. If you screen 1,000 patients who are admitted, one patient may have mucormycosis, that too not during admission, maybe 3 months even beyond discharge. So you have to have a educative effort where the patients and the treating COVID care team are made aware of the red flag signs and symptoms, at which time an ophthalmic and an ENT consultation should be advised and a bedside nasal endoscopy should be performed. Early warning signs are important to understand. There is a possible role for adjuvant posaconazole in high-risk patients. So, moderation of steroid use, moderation in tocilizumab use, awareness of red flags, an appropriate timely ophthalmic ENT consult, a high index of suspicion, combined efforts by a multi-specialty team, and timely surgical and continued medical management are critical in ensuring survival. Of course, we have to generate evidence for prophylactic use of posaconazole and also kind of understand why this is happening in the second wave more frequently. It is multifactorial for sure, and understand how our management protocol currently that we propose is going to work as these numbers increase, as we see more and more patients. This is the QR code for the IGO article if you want to download. Thank you so much.
Thank you